Hello, everybody, and welcome to the PhenoTips webinar series here. Today, we are going to be talking about preparing electronic health records for the genomic age. And this has been a very hot topic, I think. And so we really wanted to be able to dive into this more. So welcome to everybody that is starting to pop into our live webinar here, or for those that are listening to this later in the podcast format, thank you for clicking on this episode and being interested. I am very interested and excited to be interviewing Dr. Marc Williams today so we can dive into learning so much about Dr. Williams' background. He really is a perfect person to be interviewing on this topic. So thank you, everybody who is trickling in. For those that haven't tuned into the PhenoTips Speaker Series before, I am going to interview Dr. Williams here for most of our session, but you are going to have questions throughout this. So what I want you to do is, if you are listening to this live, please use the Q&A box at the bottom of the Zoom. Pop in those questions that you have throughout. We'll get to those questions at the end, but I don't want you to forget them. So please just put them in as you're thinking of them, because maybe Dr. Williams says something and then you're like, oh, well, what about this? Please pop those into the Q&A box, and I'll try to remind you kind of throughout, but please put them on in there, and feel free to, ask whatever's on your mind. For those that are not familiar with PhenoTips, I don't know how that's the case, but PhenoTips offers a complete EHR integrated solution for medical genetics. So software and services that reflect diversity of modern families, and it eases genetic professionals' workflow. PhenoTips Genomic Health Record includes tools like inclusive and automated pedigree builders, specialty-based family history intakes forms, human phenotype ontology capture, diagnostic insights. I mean, the list goes on and on and on. There are just so many features that just make our lives easier working in genetics and genomics. And a lot of us have experienced through all the different EHRs, EMRs that we've used, it's not built for genetics, right? Have you ever come across one that's built for genetics? That's what PhenoTips offers. So the genomic health record fills in those gaps that other EHRs just fail to provide, for us being very niche in genetics, so that you have that unified and seamless genetics workflow. So for those that are just tuning in, my name is Kira. I am your host for this webinar. My pronouns are she, her. I also host DNA Today, which is an award-winning podcast for a few years. We've gotten the Best Science and Medicine Podcast Award. And we've got nearly 300 episodes in the last 11 years. And we have genetic conversations just like ours on this webinar today. My other hat is I am a prenatal genetic counselor, so I see patients a couple days a week. But more importantly, our guest, Dr. Marc Williams. Dr. Williams is a pediatrician, a clinical geneticist, and a clinical informationist. He's a professor and Dr. Emeritus of the Department of Genomic Health at Geisinger. He was the co-PI of the Geisinger Electronic Medical Records in Genomic eMERGE project. Can you guess why we had him on today? He was the medical director of Geisinger's Undiagnosed Disease Genomic Sequencing Clinical Research Project. His current research focus is on the implementation of genomic and precision medicine. He serves on the NHGRI Genomic Medicine Working Group, and he's the past president of the American College of Medical Genetics and Genomics. Dr. Williams, what a treat to have you on today. Thank you so much for taking the time and joining us.
My pleasure. We'll see if you think it's a treat afterwards, but I'm pleased to be here.
Oh, I think I will. I'll take you up on that challenge. So, Dr. Williams, I figure we could start our conversation. And as I said, people listening, if you have questions, because you will, throw them in the Q&A box. But my first question is kind of looking at what the current limitations and challenges are that exist in the EHR system. So electronic health record, some people refer to it as electronic medical record, EMR. So how are we kind of dealing with, and what are the current limitations and challenges when it comes to genomic data and handling that in the traditional ones that exist? Because a lot of people that work in big health systems have kind of the same few, right, that we see, especially in the US here.
Yeah, so I think what we're dealing with is, the challenges of being an emerging specialty, if you will, coming into an environment that's really a built environment for more traditional medical care. And So while current electronic health record systems are very good at representing traditional laboratory data and have come up with solutions for incorporating images through ancillary systems called PACS, where you can archive the X-ray or CT images elsewhere, but then they present themselves in the electronic health record environment in a seamless fashion, such that it appears to the end user that they're still in the EHR, even though we know that the data and images are being stored elsewhere. We haven't gotten to that point yet with genomic data. There are a number of issues related to that. One is standards of how to represent the data in the electronic health record, communication of the data from a laboratory that's generating the data to the electronic health record in a way that doesn't require manual entry or just basically scanning a PDF, which is sort of the state of the art now.
Unfortunately, yes.
Yeah, unfortunately. But I mean, in some sense, we're at least getting data in there in some way, shape, or form. But if we want to really assist clinicians with how best to use the data, we have to have it represented in a way that's computable so that we can actually attach decision support or educational point of care information to help with interpretation, and also then to be able to go back and look at utilization. We have to be able to have coded data that we can collect. So right now, representing the data in a computable form is the biggest challenge, and there's a lot of different permutations to that particular aspect.
Yeah, and you mentioned something in terms of being able to attach more information to it. So decision making, and I'm thinking maybe you're referring to, and maybe I got this wrong, but looking at, all right, if we established a variant as pathogenic, how do we get there? Like, what is the data behind that? What are the studies to say, okay, this variant actually is pathogenic, as opposed to we're not sure, variant of uncertain significance or completely benign, somewhere, within that spectrum. What do you want to see in an ideal world as a way of connecting that? Is there certain other databases like ClinVar or something that you would want to attach to that, or just straight up studies from PubMed? Like, what kind of information do you want to see in an EHR to be able to have that be connected?
Yeah. So I think there's a really interesting underlying assumption in the question that I want to explore, because it's been the area that I've been particularly interested in researching. And it's really not what I would want to see as a geneticist in the EHR, but what do clinicians that are not specifically trained in genetics need to have in the EHR to be able to do this? Because I think
Very good
one of
point,
the
because you
things,
can look up things and you know how to navigate
right,
things and like, yep,
exactly.
this is how it works, but someone else needs that information right in front of them.
Right. And also, what do they really want to do with the information? And what we've heard consistently is that, for the most part, individuals say, give me information that's actionable. Give me something that tells me what I need to do to be able to manage this patient in front of me with a condition that not only have I never heard of before, I'm not even sure how to pronounce it. And so this was a focus of the when we were building out the newborn screening act sheets through the National Coordinating Center that was led by the American College of Medical Genetics and Genomics, and continues to be the focus of that today, which is to say, how can we synthesize the information on these disorders that primary care clinicians are going to be faced with in the context of a positive newborn screen, to say, here's a one paragraph about what this disease is, but here's what you need to do right now to be able to manage this kid. Maybe you change the formula. Maybe you initiate a referral. Maybe you need to consider starting a medication. But this is what you need to do right now. And then here's how you transition the care of this individual to somebody who has specialty training. And then put that information in their local context. In other words, if I'm in Colorado versus I'm in Connecticut, I need to know, what do I do in Colorado to make sure that this individual is appropriately treated versus in Connecticut where there may be a different set of specialists or locations that need to be done. And so that was in response to what the end users was telling us, this is what we need to do to manage these individuals. And so we've been trying to broaden that concept so that when we think about genetic information going into the electronic health record, how can we configure that so that the end user finds it useful? And to me, it requires not using our typical model, which is, hi, I'm from genetics and I'm here to help you. And we essentially end up confusing people, but really saying, what can we do? Here's a problem that you're going to encounter, whether it's hereditary breast cancer or it's Lynch syndrome or it's a metabolic disorder, or it's a cardiomyopathy. What do we need to give to you to be able to effectively manage these patients? Because we're just not going to be able to use the traditional genetic care model as we expand genomic medicine.
No, especially I think you bring up a really great example with newborn screening of you have all of these babies that are being tested and I'm not sure exactly, you know, how Canada and the UK, because we have a lot of listeners and viewers from there, but in the US, it's an opt-out process that I haven't heard of anybody go through in terms of having newborn screening. So virtually all babies born in the US past few decades have gone through newborn screening. And when something comes up and is highlighted of, okay, this condition might be here because the screening is positive, we have steps in order to get to the next part. But newborn screening only has so many conditions. And every state's a little bit different with that in the United States. But now we're looking at, in genomics, doing whole genome sequencing or whole exome sequencing. We're not there yet, but we're testing this out. Like Brady Children's Hospital is a really big leader in this. And we've had Dr. Kingsmore on this show before. And it's like, that's going to come up with so many more conditions that pediatricians have never heard of. If it's on newborn screening, I would think pediatricians have heard of that in terms of what's on today. But just the education aspect and having that in there with the tools that we already have, like we don't have this infrastructure right now.
Yeah, and I think that you know, there's a essential educational question in there as well, which is, you know, our educational model frequently has been, well, let's try and create little mini geneticists or genetic counselors, and that's probably not a sustainable model either. So again, if we can, the thing that really got me interested in the use of electronic health records, and this is now almost 20 years in, is when physicians have a clinical question comes up, they want it answered quickly right at that time. And so the educational approach has to be one that's point of care and just in time. How do we give you the information that you need right when you need it and in a trustable format so that when you see that information, you know that it's accurate and can be acted on. And so those are the types of questions that I think are really important for us to be addressing right now as we think about genomic information coming into the electronic health record.
Oh, certainly. And as you said, you've been kind of entrenched in this for 20 years and you've had a lot of different roles at Geisinger. What specific hurdles have you encountered that we haven't talked about yet in terms of integrating this genetic information into EHRs? Because again, you have 2 decades. So I'm like, how can I whittle this down into the next 45 minutes to get so much expertise from you?
Yeah, so I think that the issues that we've encountered are not dissimilar from other institutions that have implemented genomics, and that is that there's still a lot of reliance on manual methods and custom methods. In other words, we can build a system that works to deliver genomic information, but it requires a lot of manual entry of data in a computable format. It requires a lot of generation of educational materials that's specific to that data, and it works. But if I try to move that from my system to somebody else's system, it doesn't work. And so we don't have generalizable solutions. And it's, again, it's one thing to have a system like ourselves or Mayo or Vanderbilt where you have the expertise and you have the resources to be able to do this. But it's another thing to say, if we want to really have this level of care everywhere, how can we build this in such a way that it's actually going to be generalizable and sustainable? And that's where we really have, I think, a lot of challenges right now, because we don't have the standards built in the electronic health record. We don't have the connectivity to knowledge resources like ClinGen, ClinVar, that could be used to provide the knowledge, but are not set up in such a way that they can deliver that. And so what we need to begin to do is to think about how can we test certain use cases. And I've been a real advocate for newborn screening as our initial use case, because it is something that everybody does. I mean, 3.6 million babies a year undergo newborn screening. And so we have the opportunity there to take on a use case that everybody's exposed to. And if we can solve some of the problems using that sort of a generalizable use case, then I think we can begin to extend it to other conditions that are of relevance to clinicians across the country. So we're initiating some ways to try and think about how we might do this, so that we can begin to make some progress about generalizability.
Yeah, I think that's a great kind of workflow and like a cascade method, kind of like thinking of genetic testing, right? Of looking at, okay, well, how can we make this workflow in one area of medicine and then see what works, what doesn't work, and then apply it to different areas. Like having a trickle down effect in the oncology space, having a trickle down effect, in terms of just other types of things that come up in the pediatric space. So I think that that's going to be really, really helpful of looking at that. And one thing I think about is, we're both US based. So I don't know how much experience you have in terms of what other countries are going to have in terms of hurdles, because I imagine some of the problems we have in the US of, as you said, being so fragmented. We don't have universal health care where there's one system where you can implement in one system and it affects everybody in the whole country. Great. Whereas in Canada and the UK, they have more of that setup. Do you think that I'm on the right track, that there are less hurdles because they have a different healthcare system and just a smaller population? Or are there things that I'm missing? I'm like, oh, well, what about this in terms of hurdles that they'll have that's a little different from the US?
I think there are, at least in theory, there are fewer barriers because of the universal nature of the care. But there are a number of the barriers that are common that, we do need global solutions. A lot of the coding systems, like whether it's ICD, to describe the disorders, the ICD system is very deficient when we talk about the rare and ultra rare disorders that are frequent in genetics and genomics. And so that's an issue that everybody is still kind of dealing with. We have emerging standards for the representation of genomic variation, but not to the point where we can, readily implement that into electronic health records. We've talked about there are, different systems, there are different reference systems. We're now recognizing that, our current reference genomes are really underrepresented when it comes to diversity. So the application of those reference sequences to other countries is not something that we can just automatically turn on and say it's going to work. We pretty much know it's not going to work. So work on pangenomes and local references is going to be important. We are looking though, and we've have been talking about how the ClinGen allele registry, which is trying to create a unique identifier that maps to all of the different variant representation systems, is one way that we might be able to do something more globally, where we can say this is the way we're going to represent this, so that if this variant is represented with the ClinGen allele registry in the US, it'll work in Canada, it'll work in the UK, it'll work in Africa. And I think the GA4GH group has been doing a lot of work in terms of trying to create international standards that are going to move this forward, but there's still a lot of work to do.
Yeah, no, there definitely is. And you mentioned quite a few impressive projects that are really helping to close this gap in terms of our database for genetics being very European centric. And so it's in terms of ancestry, and that it just creates so many terrible downstream effects for people that don't have recent European ancestry to be able to figure out variants. And there's just, it leads to a huge, discrepancy in care. So I think that's something that is one of my many soapboxes that I get on. So I'm always, really grateful when guests bring that up and everything, because that is so important. And I'm glad that, the Pangenome Project is happening out of the NIH and everything. So I think that there's just a lot of important aspects to that. How do you see, as we start implementing a lot of these strategies that you've talked about and overcoming a lot of these obstacles, how do you see EHRs, EMRs being able to really be more effective in helping patients directly? Because the reason we do all this all comes back to, can we help patients more efficiently, faster, and just more people? So how do you envision EHRs evolving and just getting better in that context of patient care?
Yeah, that's another area of interest, and we've actually done some work. We were one of the first PCORI funded projects to look at genetic and genomic conditions, and we were particularly interested in saying, could we use patients and families to actually build a patient-facing genomic test report? Because we do believe that it's going to be increasingly important to have patients that are actively engaged with this. And so having information resources that are directed at patients, as well as those directed at clinicians, I think will make for a more powerful and likely will improve outcomes. Now, the other thing that's really important about this that is particularly a challenge in the United States, given the way our healthcare system is disorganized. Won't even use the term organized with it.
No, you can't.
Is that if you think about sequence, the one thing that's really different about, I'm not a genetic exceptionalist. I think we've gone way overboard in a lot of different situations there. But there is one thing about genomic sequence data that is exceptional, and that is it's persistent. If you get a chest X-ray or you get a electrolytes or you get, a skin biopsy or something of that nature, those results are relevant, but they're relevant for a very limited period of time, and they're relevant for a very specific clinical context. Whereas genomic sequence, germline sequence, is relevant over the lifetime of the patient, and it's relevant for a lot of different clinical contexts. And so one of the things that we need to think about differently with sequence as opposed to other types of tests that are done is, how can we reuse that? Because the economic argument is, even though it might be relatively expensive to generate that sequence, although I think that's becoming less and less of an issue, we can actually amortize the cost of that generation over the lifetime of the patient by reusing that at different cases. So, we maybe generate it in childhood because there's a question about development or something of that nature. But then as the child gets older and they're thinking about starting a family, well, we could reinterrogate that relating to carrier screening. Maybe they're going to be on a medication where we could use pharmacogenomic information relevant to that. Maybe they have an adult onset disease that's of some relevance. So we can go back to that sequence over and over and over again, but we can only do that if that sequence data somehow follows the patient as they go through the healthcare system. And so our healthcare system, the data now is EHR and institution centric. It's not patient-centric. And so what that is going to ultimately result in, if we don't change, is a lot of waste, a lot of redoing, and this is something that ultimately is economically less sustainable than a model where we can reuse that sequence. So that is an entirely different paradigm that I think is really interesting and is deserving of a lot more research.
Oh, definitely. I think that was just so well spoken, by the way. Just everything you just went through is just so important. And that also brings up the question of, we talked about at the beginning of, okay, we want this information in terms of this is the variant and this is how we got to classify that variant. And then here are the next steps in terms of the treatment and all that. But backing up all the way to what you said in terms of sequencing this genetic information and how this can be used not only for whatever reason they did the genetic testing, but that information, especially if it's exome, genome that we're really starting to order more of and less panels, that can be used throughout that person's life, and not just in the area that they did it for, but in general. If I go to dermatology, they might be able to say, oh, well, you have an increased risk of skin cancer because of this variant. Maybe I originally did the testing because I was going for, maybe even if we're looking way far in the future, I had my exome done when I was still in utero, right? So it's just how much information we're getting, but then how that can follow down in all of these different areas of health. But what we talked about at the beginning was, okay, you could have a variant and the classification and the treatment, but what about having all of this genetic information that is, I don't even know how big. Someone in the audience is going to have to tell me how many gigabytes or more than that a genome or exome is, but having that information follow you and be in the EHR, because as far as I know, we can't do that, right? We can't just upload all the genetic information in terms of that raw data into an EHR. I would love it, but I don't see how that's possible right now.
And I'm not sure that's desirable either, because the EHR is really for transactions. And so what that means is that there's a real importance for that to perform quickly. And if you load a lot of data into the EHR, that's going to degrade the performance and ultimately will lead to less satisfaction. And this is exactly why some of us have been proposing a model that's similar to the picture archiving systems, the PACS systems. We don't store all of the image data in the EHR, but we have a system that is intimately connected to the EHR where we can call up those images when they're needed in a very rapid fashion, but we're not, stuffing all of the image data into the EHR environment itself. So this sort of an ancillary system that works seamlessly with the EHR seems to be a reasonable solution to deal with the issue of there's a whole lot of data to store. And of course, there's an ongoing debate about what should be stored. Should it be a variant call file? Should it be a G variant call file? Should it be the BAMs or the SLAMs or the CRAMs or any other of these other formats?
All the acronyms.
And there's arguments for and against how to do that. That, is something that I think we will kind of land on. But I don't think that there's anybody that's strongly advocating at the present time to put it in the EHR per se, but it has to be readily accessible in the EHR. And this is something that, one of the funded projects that I have right now is sort of a future vision, which is to say, let's say, just as you put forward, that you had sequencing done in utero. And so we've got your sequence. What if you come in to the office, and in the context of presenting information from history and physical, and maybe some laboratory tests, we can say, from the computer perspective, oh, we think this individual has a genetic condition. Well, maybe the clinician hasn't thought about that. But if we had that sequence, we could actually do a test in silico saying, oh, we think this person has, based on this imaging study that was just done, that they have polycystic kidney disease. Let's look at the genes that we know are associated with polycystic kidney disease and say, is there a pathogenic variant that we're aware of? And then you can return that to the clinician. And so even though they didn't necessarily even think about a genetic disorder, they're now getting a result that says, we think this person has this genetic condition. Here's what we recommend. And we actually tested this by looking at historic EHR data at Geisinger for individuals with a genetic form of epilepsy. So we looked at 20 plus individuals, and this is work of Nephi Walton, who's currently at the NHGRI. We looked at 20 plus individuals who had a genetic form of epilepsy, and we asked the question, from the time that they had their first seizure, how long did it take us to make a diagnosis of this genetic form of epilepsy? And the median time was 3.5 years, with a range of 2 to 14 years, okay? Well, part of that is because we're not thinking about that this could be genetic, even though we know the genetic burden of childhood epilepsy is approaching 50%. And then, of course, there's all the issues of how do we get the testing done, what testing do we do, et cetera, et cetera. But what was really interesting was when we looked at those individuals and we asked the question, how were they treated? 50% of them had a medication, anti-seizure medication that was used empirically that was contraindicated based on their genetic diagnosis, either because it's known to be ineffective or that it might actually exacerbate seizures. And so think about then putting that scenario of I've got a sequence, the child shows up with a seizure, we look at the genes that are known to be associated with epilepsy, we identify a variant, and we can send that to the clinician and say, hey, this patient you just saw with a seizure, we think they have epilepsy because of this condition. Here's what you do to confirm it. And by the way, we would recommend that when you initiate your empiric therapy, that you probably start with this medication, and whatever you do, don't use that medication because it's likely to make things worse. And so we think that that type of an approach could be applied across many, many different types of genetic conditions, and we're in the process of testing that out now in several different areas.
How exciting, and just how much that can impact one person throughout their life, multiplied by, you said what, 3.6 million new babies born in the US every year. Like, so just how much that this is going to have an impact. Do you see this as a way of, there is almost like, I like, this is a new concept to me, that like the images from X-ray, this, that, whatever, are off-site, but you can kind of almost preview them. So do you see maybe a system where, because I agree, having all the genomic information on the EHR, oh my God, it's going to work even slower. Like, no, that's not a good idea. I'm glad you're like, oh, let's not do that. So looking at, is there a way to have it like, oh, click here or something to be able to browse or like go through the genome in some way where you could filter through, like in your really nice example for patients that are experiencing a lot of seizures, and they're like, okay, is there a genetic cause, where we could go through and say, oh, filter through the genes that we know have a role in seizures, and now come up with this, if there's any variants of uncertain significance. Someone's agreeing with me on the Zoom end. Any variants of uncertain significance or pathogenic variants, and it can filter through that way. Or the way that you're explaining this, are we close to being able to do that? Is that a further dream goal? Like, how realistic is that to be able to start doing? And obviously it's going to depend on what context. If you're talking about Geisinger, that's going to be different than, some of these major EHR companies.
Yeah. So I think the answer is we're very close, and we've actually, because of our population exome sequencing project, MyCode, we've been able to actually take a look at some of this. And so we've been working in particular, and the reason I mentioned polycystic kidney disease was because our nephrologists are actually very interested in some of the genetic renal disease. And so they're beginning to interrogate the exomes that have been generated as part of our population sequencing program to say, well, this person just presented with a glomerulopathy, or they presented with this type of atypical form of hemolytic uremic syndrome. Can we look at the genes that we know are associated with this and identify individuals that are, you know, likely to have a genetic cause? And in fact, they are finding these individuals. And then, of course, we do confirmatory testing to make sure that this is in fact the cause. But it can also be used for discovery, because we know that not every form of polycystic kidney disease right now, with the genes that we know, are able to be identified. And so we're also able to move into our research world and say, can we do discovery? Can we find new genes that are actually associated with this particular phenotype? And so I think we can do that. I think it's an interesting model that you are thinking of. Well, can we, could I click on a button and order a test, essentially an in silico test? And you could certainly do that. But as I referenced earlier, one of the problems is that we don't think about the fact that there might be a genetic cause. And so the question is, do we need somebody to actually click that button? Or could we put together, a confident enough phenotype from the electronic health record data that the electronic health record says, I'm clicking the button. There's enough here, and I'm sending you the information. So this is work that builds off of some of the work that Lisa Bastarache has led at Vanderbilt, using electronic health record data to identify individuals with genetic conditions. And as I started to see the work that she was doing with the Vanderbilt EHR data, and being able to say, hey, we find people with cystic fibrosis, we find people with Marfan syndrome that have never been tested. We're looking now to say, how can we extract those phenotypes, if we have the sequence, then do that testing without somebody putting two and two together and saying, oh, maybe I should do a genetic test.
Wow, this is going to change the way that we approach genomics in the sense that it's a little backwards, because we're used to someone presents with symptoms and they go to a healthcare provider. Maybe they start with their GP and eventually they get to someone more specified. So taking Marfan as an example, maybe they are having some cardiac issue, and they are brought into a cardiologist who then is like, I can diagnose a heart defect, a heart difference. And then, you also seem to be quite tall. You have very long limbs, and your chest seems to be a little concave. I'm thinking maybe Marfan. And then they're like, well, now we're sending you genetic. So instead of going through that whole route, opposite, as soon as there's symptoms in the EHR that there are, okay, we're seeing, these ones that I've mentioned, the EHR with maybe some AI thrown in there. I'm surprised we haven't brought up AI yet, of AI thrown in there, kind of a red flag. Hey, heads up, potential diagnosis or differential diagnosis list. Could it be one of these conditions? The potential variance behind that is this. I mean, that would be a major difference. Am I getting that thought process right in terms of what you were thinking?
So I think there's a lot of opportunities there. And it's interesting that you bring up some of the imaging studies, because there has been work at Geisinger and other places to say, well, we know that there are a lot of people that have had abdominal CT scans. Are we missing individuals that might have abdominal aortic aneurysm, who, because they had the CT scan done for some other reason, this may have been noted incidentally, but it wasn't really flagged to the point of intervention. Well, we can actually, use algorithms and augmented intelligence to do measurements. And when applied to the abdominal CT scan library that we have in our PACS system, we've identified individuals who have high confident abdominal aortic aneurysm, but has never been flagged. And we can now get those individuals notified so that they can go in and have interventions prior to having a catastrophe. Well, you could imagine if we looked at chest CT scans, and we're starting to do this now in another project that I'm running, where if we can do automated measurements of the thoracic aorta and identify individuals that have dilation of the thoracic aorta, we know that there are a number of genetic causes for that, Marfan syndrome being one, but there's also a number of other genes that are associated with that. Could we, in fact, then identify those individuals and identify those that have genetic causes and get them in for management, either pharmacologic management to slow progression of the aortic dilation or aortic replacement in an elective fashion prior to, again, catastrophic rupture that is associated with a 40% mortality. So I think there's lots of opportunities to begin to explore how we can generate indication-based sequencing, because what we don't want to do is to get a sequence and say, oh, let's look at the 1,000 epilepsy genes in everybody, and we'll let those people know if they have a variant. Well, A, they're all going to have variants.
Yeah, I was going to say everybody.
And the vast majority of them are never going to go on to have a seizure. So we don't want to do population screening. There are situations where population screening is absolutely important. We're demonstrating that in hereditary breast and ovarian cancer and Lynch syndrome and cardiomyopathy and things like that, where we're demonstrating not only does it have clinical value, but it's cost effective to do that. But that's a very small group of disorders that we're going to use a population screening approach for. What I'm really talking about here is using pre-existing sequence to do indication-based testing, but using novel ways to generate the indication to pursue the test.
Right. We need a threshold. Otherwise, as you said, everybody in an EHR is going to be alerted that they have a variant.
Yeah,
Like we
it's
both
just
sitting here have variants.
basic Bayes, right? Prior
Yeah,
probability.
there
We
you
need a
go.
high prior probability. So
Yes. Yeah, definitely. And I'm even thinking like in this scenario, and I see some questions popping up. So everybody make sure you get your Q&A, or we'll do the A part. So put your Q's in there. But I'm even thinking with this workflow of, let's say you do identify someone that has Marfan. I'm thinking, all right, well, their siblings should be alerted, their kids, right? So when, us working in genetics, we're like, of course, right? The downstream effects. We have one patient, but there's a lot of kind of sideline patients, if you will. So that kind of, it's like, I want it to be able to alert to them, hey, you have a relative, blah, blah, blah. But then it's like, well, are we then breaking HIPAA? What is that line between the privacy of information and making sure that information and data is all secure? And there's different things like blockchain technology and everything. But it's like that duty to warn versus HIPAA, that classic kind of talk of, at what point do we warn people? How does that go? Because it's going to pop up even more if we have EHRs kind of recommending differential diagnoses.
yeah. So I'm going to take one step before we get to the HIPAA and disclosure issue to identify another weakness of electronic health record systems for genetics, which is back in the day, I'm old enough that when I started practicing pediatrics, I had a nice paper chart, and all of the kids of that couple would fit into this one paper chart. And
the good old days.
They were all there, okay? They were linked. Well, in electronic health records, those family records, that family linkage is not evident. And so even if we're really interested in potentially notifying other family members, we have no way to identify those family members in the electronic health record at the present time, because those familial linkages are not present for the most part. There are some groups that have, again, begun to explore how this could potentially be done for the very reasons that you bring forward. But that's a technical issue in electronic health record environment that is to be solved. So now, if we assume that we do solve that, the question then comes up, which is what are we allowed to do and not to do? Now, again, our other people at Geisinger are beginning to explore this issue along with other places, which is to say, our current model is we rely on the individual to say, let your family know, and we'll maybe provide them with some information and try and help. But we do think that there are ways that do not require that family member to sort of be the person that distributes the information. So we've been exploring technical solutions using chatbot links and other ways to directly notify. I think there's some work that's come out of some of the other projects that are NHGRI funded looking at direct contact. And frankly, there are, HIPAA does not prevent that from being done if you in fact have let the individual know we need to contact your relatives. Is it all right for us to contact relatives? They can do that. And any information that the person provides about relatives and contact information, if it's in their record, that's fully shareable. That's all part of their record. So there's no special protections related to that. So I think, again, we tend to be, and when we certainly talk to our legal offices at our institutions, they tend to have an ultra-conservative interpretation of what HIPAA says. The reality is that HIPAA doesn't necessarily say everything that we think it says. And so we probably have more latitude. And it's going to be important as we think about these cascade scenarios that we explore innovative ways to do that communication, because relying on the individual who has their life to live and it leads to lower engagement with family members who are at risk.
Yeah, no, that definitely makes sense. And it's interesting that, I think HIPAA is something that we're all like very concerned about in a good way, right? We should be, but like, okay, duty to warn often will be more important than HIPAA, and the things that we're thinking about with HIPAA may not even apply to these types of scenarios. So I think that's really helpful. Well, I have so many questions for you, but I've had my time to ask questions. So we'll pop over to some viewer questions, people that are watching us live. So if you are watching and you're like, oh, I also have a question, but I don't know if I should type it, please type it. We'll share it. So the first question is about a specific EHR, Epic. So I'm sure you've heard of that one, right? Do you have any experience with genomics within Epic? If you do, how would you describe it to an organization with many research sites, including international, that's interested in implementing it? Pros, cons. So it sounds like this person's like, should we use Epic? And they're coming from a genomic perspective.
Right. So Geisinger has been an Epic shop since the mid-1990s. We're somewhere either the second, third, or fourth institution that adopted Epic. So we have a very long experience with them. And as those of you who are using Epic may know, over the last couple of years, Epic has introduced a new functionality called Genomic Indicators, where they're trying to support now some of these genomic representations of data. So they're definitely interested in this. They're hearing from their user community that these genomic use cases are becoming increasingly important. We're having some discussions with them about how we might be able to utilize act sheets within Epic. I think that they are definitely open to listening from the community about what they can do to support. And we know that there are Epic groups that use Epic that have successfully implemented pharmacogenomic use cases, other genomic use cases, and that the genomic indicators also allow aggregation of data so that you can use some of the analytic platforms within Epic to say, okay, show me all the patients who have a BRCA1 or 2 genomic indicator, these sorts of things. And that can be tied into problem lists. So we're making some progress there. It's slow, and it, the old saying is, if you've seen one implementation of Epic, you've seen one implementation of Epic. And that's certainly true when it comes to genomics. So again, this whole issue of generalizability continues to be a major challenge. But there are some population health solutions that Epic has been putting forward that we hope will provide more generalizability. And then we're also interested in exploring their care everywhere which is their solution so that if I'm being seen, and this is relevant for me because I live in Wisconsin, but I work in central Pennsylvania, and I
Oh,
have
really? I just
care
assumed you were in
at
Pennsylvania
both
because that's where
places.
Geisinger
So,
in. Yeah.
so I have and both of my healthcare providers are on Epic. So if I get something done at Central Pennsylvania, the Care Everywhere allows my doctor in Wisconsin to be able to see it. So we're making some progress with some of this interoperability. But it's, in terms of the research solution, it's really important to note that while we employ Epic heavily for research purposes, it's not what it's designed for. And so if you want to use Epic for research, you're going to have to commit yourself to investing a lot of time and effort. We affectionately refer to it as data torture, where
Oh,
we put the data in a room and we torture it until it gives us an answer.
yeah.
It may or may not be the right answer, but it's not built for research. But it can be used for research, but it just requires a lot of effort. And there's no sort of off-the-shelf solutions that will. This was a lot of what Emerge was working towards,
At
which is
Geisinger, the project you were doing.
find
Yes.
these generalizable solutions. And while we were able to have some success, it wasn't something that is easy to do.
Yeah. And how can we get to that point then? Because a lot of these EHR, EMR companies, they have to take into account so many different areas of health and so many different specialties. So they certainly, I mean, that is definitely quite a challenge to take on. So they can't please everybody. However, being all genomics people here, obviously we want our genomics aspect of EMRs to be the best it can be. So we have another question here saying that there are so many EHR vendors. How can we encourage these companies to develop modules that are scalable and can be integrated from more quickly with lab providers? Integrations can be costly for labs. So how can we, talk and encourage EHRs to be able to develop this? This person's kind of asking about lab integrations, but, also just to make it easier for us in genomics, but also, as we've been talking about over the last hour, of having other healthcare providers be able to have access to that genetic information, because it's not just us that need it. It's not just like we're in this little area that only affects our area. Our area affects every other area.
Yeah. So standards are at the base of this. So we have to have agreed upon standards in laboratory information systems, in electronic health record systems, and other systems that allow for that interoperability. So standards are necessary, but they're not sufficient to generate the type of ecosystem that the person asking the question is really looking to get to. We have to have I think it has to start with use cases where we can all agree that this is something important. That's why newborn screening to me is a really good use case, because it's something everybody's dealing with. And I think that while there are going to be certain aspects of newborn screening that are unique to newborn screening, if we can develop a generalizable solution, there are going to be parts of that solution that are going to be reusable if we want to, say, do population screening for hereditary breast and ovarian cancer, or if we want to do population screening for Lynch syndrome. And so as we build more and more of these generalizable use cases, we're going to have more and more components that we can reuse. And so the second part of the answer is we have to think in a modular way about building solutions. So we don't build an end-to-end solution that works great for that one particular use case, but won't work for anything else. We consider what are the modules that, perhaps are good enough, not perfect, but good enough, but we can then reuse these for multiple different solutions. That'll move us along faster. So I think that, modularity, standards, those are important. And then I think the other thing that's going to drive this, and we're beginning to get to this point, a lot of what happens in electronic health records in terms of what data do they collect well relates to quality reporting and outcomes. As we get paid more and more for value, meaning we have to demonstrate that we have a good outcomes and we're providing quality care, if we can define some quality outcomes around some of these genomic cases, EHR vendors will need to build to capture those outcomes. And a lot of that is going to support some of the other uses that we want to do for that. So, we're just at the beginning now of getting enough momentum to say, perhaps, as quality is built around colorectal cancer care, maybe we could carve out a piece of that related to Lynch syndrome, where we could have quality indicators that are specific to that. So, those are the sorts of things that I think tend to drive EHR vendors to innovate and expand.
Yeah, yeah, definitely. And I want to get to another viewer question here saying that kind of relates back to, I've brought up classifying variants a lot. So they have another good question, just in terms of like patient lifespan with this information. Do you think that, using the EHRs on a continuous manner, connecting to patients, can also help in reaching patients many years down the line and conveying updated classification of variants? So if someone right now is getting a VUS, and 10 years from now, which is an eternity in genetics, it gets updated to especially pathogenic, where there's maybe things that we need to put in place in terms of medical management changing. Do we see EHRs being able to be a tool in that? So in that patient file, there is an alert or something of that nature.
Yeah, and again, this is a larger question because, of course, it really comes down to population health management. And when we have people that are shifting into different systems and that, even saying, well, have they had a mammogram? Have they had a colonoscopy? We can't even convey that kind of high level information at the present time in an effective way. So in some ways, getting down to, can I update a variant through the EHR is several bridges beyond that. But I
Yeah.
think everybody recognizes that this type of population health approach, where again, we're talking about patient focused information, and the information moves with the patient rather than being siloed at an institution or in a specific EHR. We're ultimately going to have to get to that. And if we can get to that, then we'll also then have to build solutions about how, if we have a variant reinterpretation, we can then get that to the patient and the patient's provider wherever they happen to reside. So yeah, the critically important problem. And given the dynamic nature of our information around the the patient, I think that and the genome, we're going to have to solve it. I think there are some laboratories that are creating patient portals where they're kind of cutting to some degree the EHR out of the loop, because the EHR right now really can't support that, but saying, we need to maintain that connection. So that's a temporary solution, but it wouldn't be, in my view, a long-term solution for how we do this.
Yeah, I think that makes sense, of just like, okay, we can't, that's having the information, as you said, like siloed, of like, okay, it's stuck kind of at this one genetic lab, which is what we're dealing with today. So it's kind of a Band-Aid fix in terms of that, but it will be interesting to see how that goes in the long term. And my last quick question for you, that people will see how this ties in at the end here. How do you see the role of AI kind of having a role in EMRs and all of this? Because how is it not going to?
Yeah, so it will, but I think as I think about AI, and for those of you that are at the American College meeting, we heard the president of the AMA, who's an anesthesiologist and an informaticist. Like, I'm not an anesthesiologist, but I'm also an informaticist, and he says, we're using the wrong A. We use artificial as the A. And he says, what we really need to be thinking about, and you heard me use the term earlier, augmented intelligence, which is, computers do some things way better than humans, but humans do some things way better than computers. And it's always interesting to see the headline that says, computer better at detecting nodules in chest CTs than humans. True, but computers are not as good about interpreting what that means in the context of all the other clinical information. So humans are synthetic beings, computers are crunchers. But those two things together what we find is in those studies, and it's never reported because it's not a sexy headline, is that if you find an interface between a human and computer that's effective, the performance is better than either the computer alone or the human alone. And so I think one of the things that's really interesting and will probably expand beyond my research timeline is how do we create those interfaces, ideally within the electronic health record environment, that allows for this augmented intelligence, where the computers can do what they do, which is to crunch the data and present it to the humans with the insights and synthetic abilities that we have to really move things forward. That to me is extremely exciting. I hope to be the recipient of it in my dotage, but probably won't be leading the charge.
Oh, we might be surprised, but I agree with that. I think we need to be using AI as a tool to be able to get better at what we do and not really replacing. I think that's been a lot of headlines. Oh, will it replace these jobs, replace these tasks? It's like, actually, I think it just makes it better or more efficient.
Yeah,
But
there's a quotation that says, computers will not, and AI will not replace doctors, but doctors that effectively use computers and AI will replace doctors that don't use computers and AI.
Exactly. If you're not using AI in some way in your job, you will be left behind, I
Yeah.
think. So, but what's very exciting is that our next webinar next month in May, we're going to be exploring the role of AI in genomics. So hence why I wanted to get your take on it, Dr. Williams. So everybody, you're going to see a feedback link in your browser when this webinar ends in a moment. And we're also going to email it to you in case you've already popped off or you're hopping to the next meeting like I will be. So please take a minute to offer your feedback because it really helps us improve future webinars and make sure that we're offering you information and education that you really want to hear about. So the email is also going to include a link to the PhenoTips Speaker Series page where you can sign up to receive alerts on upcoming sessions like our next talk of the role of AI in genomics. And we're really excited to talk about that. If you want to just head over to our website directly, phenotips.com, click the resources tab, and then the speaker series is going to pop up on the drop-down menu, and you can look at all installments on there. We also have it as a podcast, so you can search the PhenoTips Speaker Series in your podcast player like Apple and Spotify. For those that are viewing, you can see that our social media handles are right in front of you. And we very much appreciate you guys tuning in, and so excited to dive into AI next month because I've been quite obsessed with it. But Dr. Williams, I have to say, you were a treat. You met my expectations and beyond, as Buzz Lightyear would say. So thank you so much because I feel like I learned so much and we just loved the conversation back and forth and stuff. I don't even know if I hit all of the things I wanted to. I knew I wouldn't, but I love all the examples you gave. This was just incredible.
Well, thank you very much. It was my pleasure to be able to participate.
Yes. Thank you so much, Dr. Williams. I hope we can have you on again to just keep picking your brain and all of the expertise that you have. And everybody viewing, thank you so much for tuning in. And if you're listening to this as a podcast, thank you so much. Be sure to rate and review and click that follow button for more episodes. Thank you so much, everybody. Have a great day. We'll see you next month.